morning, good afternoon, and good evening to all speakers and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for today is our honorable guest from Egypt, Professor Ahmad Zodi. Professor Zodi is a professor emeritus of neurosurgery and also honorary president of Egyptian Society of Neurological Surgeons. He was also the former vice dean for postgraduate study and research, Qas El Aini School of Medicine, Cairo University, Egypt. We are extremely honored to have him today in our webinar, and today he'll be talking on endoscopy for intraventricular tumor. The speaker for the second session today is our honored guest from China, Dr. Yu Jun Liao. Dr. Liao is a consultant neurosurgeon at the Huashan Hospital, Fudan University, Shanghai, China. His clinical interests are focused upon cerebrovascular and skull-based surgery. We are extremely honored to have him today at our webinar, and today he'll be talking about pressure-guided revascularization of giant ICA aneurysm. The chair for first session today of our webinar is our honorable guest from Saudi Arabia, Professor Imad Kanan. Professor Kanan is a professor emeritus at the KFSH University and Research Center. He is the past president of the International Association of Neuroanatomy. He is an expert in the field of endoscopic brain surgery, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The second chair for the second session of today's webinar is our honored guest from China and also the vice president of the ACNS, Professor Zubin. Professor Zubin is consultant neurosurgeon at the Huashan Hospital, Fudan University, Shanghai, China. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and President Professor Kato, I would like to welcome both our speakers and chairs and the wonderful audiences to this online platform of ACNS webinar. A warm welcome to our colleague in China, and we are extremely grateful to Professor Zubin for broadcasting this webinar on WeChat channel. And with that introduction, I would like to hand over this podium to our first chair, Professor Imad Kanan. Professor, please.
Thank you, Professor Bong, for the introduction. I'm very pleased first for the invitation to join venture with their nice friends and colleagues. They are experts in their field. Professor Zodi is a close friend, and he is a master in pediatric and in endoscopic surgery. I'm not that experienced with endoscopy as he is, but I'm more in the skull base. Very pleased, and without further ado, I think Professor Zodi, you can proceed with your presentation.
Thank you very much for the invitation, and thank you very much, Dr. Kanan, for your kind introduction. This is where I come from, Cairo University, Qas School of Medicine. The faculty is mounting to 200 years, and these are the relatively newer buildings built in 1932, and these are the newest building, even a fisheye effect to put you in the mood of endoscopy. Current intraventricular endoscopic procedures, it's a versatile technique. I mean, it entails nowadays the fenestration, whether endoscopic third ventricular cystinostomy, whether cystostomy, whether septostomy, restoration of the foramen of Monroe or the aqueduct by doing foraminoplasty, aqueductoplasty, excision and biopsy of tumors, intraventricular tumors, and guiding endoscopic shunt procedures. Now, I have to run very fast because I have a lot to give in spite of this allocated time, 40 minutes, yet the topic is quite rich. So to start with, your basic issue is to master the anatomy and this morbid anatomy. And as was previously advocated that, okay, you're changing the microscope with a 3D to the endoscope with a 2D. Well, it has proven beyond the shadow of any doubt in the last decade, mainly, although we started 3 decades ago, that you attain even a third D, that is through the illumination intensity and the shades, and this is acquired by time. It's a learning curve. And then the fourth E is through the motion parallax of your telescope going up and down and using different telescopes and telescope angles. and achieving hence different views. And even a fifth deal is attained by the degree of severity of the hydrocephalic changes and the duration or the chronicity of the hydrocephalic changes. So actually, you change a 3D anatomy with a microscope into a 5D anatomy. Of course, put in mind that whatever you see through the lens, you don't see behind the lens. So you have to be very careful and in command of your anatomy. There has been for a long time a trial of mainstreamization of endoscopic procedures into the new surgical practice. And I think by now this is achieved. I mean, the endoscope is now a major part of your armamentarium in the OR. Of course, it is a tedious learning curve. Of course, you have to command the morbid anatomy. Your main concern is to have the same tools that you have with the microscope, with bipolar forceps, and endoscopic ultrasound aspirator probe, the holding system, and then the port technique is either you use tubular or mini retractors in order to be able to change also the endoscopic per se into endoscopic assisted microsurgery. And this is the whole concept that I want to convey. Of course, you have a straight trajectory. You need bimanual dissection. You need to use all your tips and tricks in the hemostasis, the profuse irrigation, the balloon pressure, and tamponade, the small chamber irrigation technique, and the dry feed technique. And of course, you have to select what kind of lesions that you're going to deal with, their size, their pathology, in order not to have a misfortune or a disappointment. So you have to be some sort of choosy, and you have to always be flexible and turn from endoscope alone to endoscope assisted, because you have all the tools and you are trained for both. Now, the first procedure that you do, for example, unilateral hydrocephalus is septostomy. And you do your septostomy through the wider ventricle or the widened ventricle into the more or less lesser sized ventricle. So you have to take care. You have to do the puncture in the most transparent part of the septum pellucidum or the septum virgi. Of course, the border is between both septi is the foramen of Monro, and you go whatever, anterior or posterior to the foramen of Monro, and you do your septostomy in the most transparent part. But of course, take care, it should be guarded as you do it, because you should not injure the contralateral wall of the ventricle. Now, these are the concepts that were put by late Professor Axel Penetsky 3 decades ago, and how you should approach and what can you approach through this Kocher burr hole, which is actually the sort of keyhole of most of the endoscopic surgeries. The most common one is the ETV. It stands for 50% of your endoscopic procedures. So you have to know that the port of entry is your foramen of Monro. You have to know the anatomy of the foramen of Monro, and you have to be ready for going through the foramen of Monro without injuring the fornices. This is one of the publications that we had, and we did this, I think, this year or end of 22, where we give a schematic illustration of the foramen of Monro boundaries and relative safety zones. You are at the safest zone when you work throughout the A zone, as you see in the schematic illustration. It's the least risk. Other than that, you might injure the thalamus. Other than that, you might injure one fornix, or unfortunately, when you function through the C area, you might cause damage to the body. So endoscopic Monro foraminoplasty is either restoration excision of a lesion or dilatation of the foramen Monro. This is again to show you the foramen Monro, the port of entry, the size, maybe pinhole, maybe a wide, as you can see, the left-hand pictures. And then in the middle, you see how we do a balloon foraminoplasty to achieve your target area, which you can see at the lowermost mid photos. And you do foraminoplasty, and then you do your ETV. This is here to show you how to deal with such a small foramen of Monro. You just unlock the sheath and you guide it in front of the telescope to make sure that while introducing the sheath and the endoscope within the sheath, you are safe and you do not injure the fornix. After the job is done and you have visual confirmation, you go back and you see that your fornix was saved and without any injury, in spite of being a small. Now, the second, the most important border or stage or step in your endoscopy is the floor. And where's the target area? And this is through the learning curve, you get to see a lot of floors, which are quite different. They differ in the size and the shape and the amount of stretch and the thickness. And I'll show you some of the cases, but as we go on, and you see here that actually the best target area is the membranous part of the tuber cinerum at the saccular recess, which is this part just in front of the basilar and the premammary sulcus. The premammary sulcus, and this is the saccular recess, the membranous part of the tuber cinerum. Again, these are easy ones where you can clearly see your target area, but here, I mean, this is quite difficult, pushed upwards and forwards, the whole brainstem and the basilar, mainly in posterior fossa lesions, equally here. And in this one, you should not stick to the midline. You should go on one of the sides, preferably this side, the left side. And again, here, you will find that the space is very tight, but of course, in the middle, it will be very difficult. You start by going lateral, and then you go medial as the CSF is released. Very interesting is to show you just films. This is what I'm talking about when you have a posterior fossa lesion pushing the brainstem and the basilar artery. And here you have to go on one side, and you'll be able to do it. Here, of course, be away from the midline. And this one is very interesting case. You don't know what it's all about. This is secondary ETV, after multiple shunt operations and infections, etc., etc. But by experience, you find that this is the area where you can do your ETV successfully and have visual confirmation. And this is what you're going to see. So these are cases as you go on, as you acquire the knowledge and climb the steep learning curve, you should share this knowledge and convey your message to your colleagues so that they would not go through the hardship that we went through in the past 3 decades. So visual confirmation done. This is very interesting. This is a redo. And this is what you see actually with the regress or repumping of the CSF in a case with ETV that blocked, and you do it again. And it's a successful visual confirmation. And this could be an explanation why cases of ETV go or lose consciousness or go into complications quicker than an obstructed chart. Just to give you some time, sometimes it is doable when you have seeding in the target area. You can do it through here. But in this case, with a seeding of a fourth ventricular tumor with alloblastoma grade 4, you cannot do it. It's not doable. You don't have a space to go through. So don't be obstinate. And I mean, you should be able to choose your cases as you go on. Now, a very important structure is the third ventricle. The third ventricle changes with hydrocephalic changes by ballooning side to side by bowing of membranous borders, especially the lamina terminalis anteriorly and the floor of the third ventricle inferiorly, or the tuberous serenum, the thinned out tuberous serenum, or the membranous part. And put in mind that the ventricular, circumventricular organs are important. For example, this is where the tear happens in the supraoptic circumventricular organ. And this is actually not a recess, it is a circumventricular organ. And in cases of the inferior rupture, it happens, and I will show you cases where you do not do, or you do not go into third ventricular cystinostomy, in cases where you are not sure if this is an arrested hydrocephalus or not. You can see all the target area, etc., etc., and the actual recesses of the third ventricle are the supraoptic, the saccular, the suprapineal, the pituitary stalk, and the pineal. Very important anatomy. We went through this ordeal and we passed through a lot of cases. We found in the MRI, in the mid-sagittal high-resolution cut, that there is an actual tear in the lamina terminalis, which we call anterior spontaneous third ventriculostomy, and you need not interfere. You will find that the patient has ventriculomegaly, but has no signs of increased tension, and he does not need this kind of surgery. Very, very quickly, it's a sort of safety valve that Mother Nature gives you. The rupture happens mainly at the lamina terminalis or in the floor of the third ventricle, more in the floor of the third ventricle. And it would be actually unethical to go into such a case because this is an arrested hydrocephalus. I'm showing you very quickly where and why, and just let us go further for more interesting issues. But I meant to just raise a flag. The site of predilection is not known. The sequence, if dual or the timing, which starts first, the chronicity, the bouts of increased tension, these are all questions to be still answered. Now, let us go for the actual surgeries. Cochlear hole is the key area. So are you going to do endoscope alone? Are you going to do endoscope assisted, bimanual, port of entry, the corridor? Are you going to follow it with an ETV or end it with an ETV and EVD? Are you planning for radicality or putting safety first? Minimal invasive concept is there. Are you going to do a tailored approach? And look at this. This is very important when you come to do the simple ETV. The first one is an acute hydrocephalus with still the medial border of the foramen tilted downwards. So the inclination changes with chronicity and with the severity of the hydrocephalus. So this is why we keep the head not fixed, because in the acute, you turn the head towards your side, and when there is a chronic case, you turn it towards the other side, but this is after looking at it and confirming it with your endoscope, in order to put the plane of your foramen parallel to the floor, and the endoscope that you are pushing through, you just have to be or stay vertical. You don't lever, you don't go anterior, you don't go posterior. This is one of the major tricks that you do safely ETVs without any problems, without injuring mainly the fornix or whatever vessels or choroid plexus. And this is the very important tailoring of your approach accordingly. Whether you have to go anterior, you have to go posterior, 1 inch anterior, 1 inch posterior, you're always safe from away from eloquent brain areas. Now the velum interpositum. What does the velum interpositum do? Apart from those changes that happen with reversing the curve and the triangle and etc., 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 the most important lesion that you get out of the velum interpositum is an arachnoid cyst, a thick arachnoid, or an encysted caving velum interpositum, and this can be solved, as I will show you later, with just endoscopic procedures. And now, this is a real interesting case of a unilateral tumor that has blocked. It is arising from the lateral ventricle, the right lateral wall of the lateral ventricle and blocking the foramen of Monro in a sort of ball and socket valve, as you will see. It is too huge to be removed. It could be actually removed in a piecemeal method. But when you come to think of it, well, we thought otherwise. But we confirmed the fact that it is not stuck and not adherent to the foramen of Monro, just blocking the foramen of Monro, as you can see here. And this is what we did. We actually removed it endoscope-assisted microsurgery, totally shaved. And then we went to the endoscope to see again what was there. And this is an additional importance and value of the endoscope or endoscope-assisted. We found sort of an ulcer in the floor of the third ventricle, juxta the floor. And this changed the management as regards the adjuvant therapy, etc., etc., etc. Okay? This is what I told you about, one of the cases of the vena interpositum cysts, and you just can do it in the scope, solely in the scope, with the scope standalone, and you do your job, cystoventriculostomy. And you have always the choice to go back, to go anterior, to stay in the middle, and enlarge, and do just a thumb-sized craniotomy, tailored craniotomy. This is an interesting case. You go in your endoscope, you take your biopsy, you remove the fluidy part of your cyst, and this is after the surgery, and this on your right-hand side is 11 years thereafter, patient fully cured, and he's still being followed up, I hope, for a long time. Another case also, and where you have to do, if you need endoscope assisted for any reason, but other than that, it is doable with the endoscope alone. Always remember these tricks and how you can extend your craniotomy. Now, neuroendoscopic surgery for colloid cysts. You are going to do a foraminoplasty actually, because by removing the cyst that is blocking the foramen, you are going to excise it, and you're going to remove the wall, and you're going to do an ETV or an EVD accordingly. If the floor is there and ready, do an ETV and have a good night's sleep and make sure the patient is safe. Our prime purpose in this life is to help others. And if you cannot help them, at least do not hurt them. The potential midline cavities, very informative and very important to know, because through them, the colloid cyst, for example, extends, and I will show you how. The cavum septum pellucidum, the fifth ventricle alone, cavum septum virgi alone here, which is very rare to see alone, and both of them, virgi and pellucidum, and also the cavum velum interpositum. And this is the diagram to show how they are related to each other. Colloid. I'm not going to talk about the pathology of the colloid. I'm going to talk to you about the origin of the colloid. Where does the colloid originate from? It is from this area somehow, but it can extend inferiorly. It can extend superiorly into the cavum septum and hence be tucked up and block the foramen of Monro, not by its size, and I'll show you. And then it could be this kind of colloid cyst, a huge one, transgressing the boundaries and going into the third ventricle and even reaching the lateral ventricle. And these are the actual examples, tucked up, the normal site, and, sorry, the transgressing one, a huge one. Site and ventriculomegaly. Is there a relationship between the site and the ventriculomegaly? I guess yes, because ventriculomegaly is very evident with cases like that tucked up and blocking the foramen of Monro, and hence the hydrocephalic changes are quite apparent. While in this case, it is not blocking the foramen, and you can see the foramen, and it is not, the hydrocephalic changes are not that big. Although there are, with the presence of a place where the CSF can be somehow find its way throughout its circulation. There is no complete block, but as you can see, it seems to be a valvular block, and hence it caused these hydrocephalic changes. The different sizes, small one with the same hydrocephalic changes, maybe here more acute, small one with no hydrocephalic changes, and equally bigger than the small one or bigger than this one. If you compare this one with the last one, you'll find the size bigger, yet hydrocephalic. I could personally find no relationship between the site, the size, and the ventriculomegaly. Are you going to do endoscope alone, endoscope assisted? Where is your port of entry? Are you going to do an ATV, an EVD? There is a strategy that you have to have in mind, and you have to be quite flexible and accordingly use one of these mini craniotomies. Now, these are actually the maneuvers that you use while doing endoscopic maneuvers in removing colloid cysts, aspiration of the contents or piecemeal removal. If you have to aspirate and still the contents are within the capsule, you start doing a trick by pushing a balloon catheter behind the cyst, as you can see here in the photos, but I will show you in the film. And you hence squeeze out the contents of the colloid cyst and you suck it out, preferably when it is even viscid, it is doable. CSF diversion, this is still a debate whether to do CSF diversion. I think the pendulum took us now all to endoscope assisted, yet the pendulum is still between, or the debate is still between to do an ETV or not to do an ETV. I sincerely believe you should do an ETV, because if you find the floor which is ready for you, do an ETV, have a good night's sleep, and make sure that the patient sleeps safely and you do not lose him at night. Not the residue you should dread, but the spillage of the irritant fluid contents into the aqueduct of Sylvius that causes the acute obstruction of the aqueduct and acute hydrocephalus, and you lose the patient. Of course, if you have a floor that is not, especially in the tucked up type of colloid cyst, you don't do a ETV because you'll find the floor thick and parrot beak shape. So you just leave it alone, but you make sure you put an EVD for 48 hours. But this is standalone procedure. This is endoscopic assisted, endoscopic controlled, microsurgery alone. The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So persevere, hope for the best, and convert and plan for the worst. This is another example of a colloid cyst where you go in to the colloid cyst with the endoscope, still having in the back of your mind the minimal invasive neurosurgical concept. You find this kind and you're not happy. You will not be able to remove it totally without injuring to any vessels or major bleed from the choroid plexus. So you enlarge your burr hole into a thumb-sized craniotomy. You do your job with padded mini retractors or tubular retractor if you have, and then you leave an EVD. And this is to show you the size. This is the mini thumb-sized craniotomy, tailored craniotomy, and you did your job. So you don't have to be dogmatic. You have to be flexible. You are capable of doing and using the endoscope, but you should not enforce the endoscope in cases where you can do otherwise, or both together endoscope assisted. Now, these are all the types of colloid cysts that you might be facing: a coapted, a displayed, a huge, a crescent foramen of Monroe, or crescentic, a large foramen of Monroe, a divaricated foramen of Monroe with the septal vein in between, dilated, recurrent, adherent, and small ductal. I don't think we have enough time to show you all, but you can see how we manage. This was a very interesting case. A medical student in his 5th year, he was complaining of his memory disturbance and was not catching up very well in his studies. And this was a challenge. And I went through the left ventricle to find this huge colloid cyst, putting in mind, I mean, he's a fellow colleague to be, and he has to have some kind of memory, not only recognition, but recall. So I decided to turn into endoscope assisted. There was no need, or there was actually no possible way of doing an ETV. So an EVD was done, and then followed by a whole 4 weeks or a month of still some sort of CSF overflow in the ventricular subgaleal space, in subgaleal space. And so some drainage was done for a while until he totally recovered, and he's a fellow colleague, thank God. These are 2 other cases. I don't think we have time. In order to stick to the time, but I have to show you this. The postoperative complications in colloid cyst. Everybody shows these pictures. Oh, what a wonderful, talented surgeon you are. Okay? Nobody shows this. See the trajectory. See what you've done. This comes from prolonged, mainly from prolonged, and from some sort of hydrocephalic changes that happened until they were released. In this case, they were released spontaneously, but you can see what kind of trajectory is there. I'm not very happy about it. This doesn't cause any harm to the patient. 2 patients doing very well. And this is another case where a porencephalic cyst even. This is a porencephalic cyst. I'm following it up. It's still not under tension, not causing any problems. And these are post-operative with some residue or even recollection, but with another type of fluid and not needing no hydrocephalic changes or no increase in the hydrocephalic changes and no complaint to the patient. A cavernoma, a very interesting one, blocking the foramen of Monroe, causing unilateral hydrocephalus. This could be done endoscopic alone, piecemeal removal with a punch, and electrode, bipolar electrode for always, and balloon tamponade until you reach your target and you do remove it totally. And this is what you get as a final result, and you can compare both MRIs. So this can be done totally with the endoscope. Another example is this one, another cavernoma, which is actually blocking the aqueduct. You do a ETV and you leave the rest for the adjuvant. She even was given gamma knife therapy and swallowed up. The cavernoma did not increase in size, although a lot advocate cavernomas do not benefit from gamma knife. And I'm still not sure, but anyhow, so far so good. These are all the types that you can do with the endoscopic options, but unfortunately, we don't have enough time to show all of them. Triventricular hydrocephalus, I always go for an ETV, and here is to show you a very tight space, but still doable. This is the case that I showed you, and showed you that this is still doable. You can do your ETV. This was a pioneer region with a seeding in the target area, but it is still doable and done. This is an interesting choroid cyst, where you just remove it with the endoscope twist it and remove it, and you've done your job. This is very interesting, the possibilities that you might find, proximal intercisternal obstructive hydrocephalus, especially after posterior fossa tumors, where you have a lot of bleeding sometime, and you get then an obstruction, the proximal intercisternal, you do an ATV and you solve the problem. Now, the mesencephalic membrane of the iliquis membrane, or actually your port of exit, where you want to go into the interpeduncular system and then pass it by and go into the prepontine system. Put in mind, the iliquis membrane with all its leaflets, mainly the diencephalic, mesencephalic, and cellular. We also describe the vertical one. It could be cuff-like, it could be sleeve-like, it could be sheet-like, it could be shield-like and tough, ill-defined, thin, double, multiple. You have to anticipate anything. But put in mind, to make sure that you've done your job, you do, for example, in sort of prepontine arachnoid cysts or interpeduncular arachnoid cysts that go upwards. If you go in with your endoscope here, then you are here. You didn't do your job. If you go here, then you are here. You still did not do your job properly because you have still the mesencephalic membrane. What you have to do is go all through to have really this result, which is a real ventriculocystocysternostomy, and successful. This is what we see actually in a building up prepontine cyst, and this is how it looks like. And this is preoperative, postoperative. Aqueduct of Sylvius, communication between the third and fourth ventricle. I know you know all that, but the main thing now, forget about aqueductoplasty. Went into a pendulum and it drove us back, and we even refrained from doing any aqueductoplasty unless you have on the proximal end a sheath or a membrane. This is the only advisable type of aqueductoplasty, a restoration of the aqueduct, not by ballooning, not by excision of a tumor or something, or tectal plate or tectal bulge or whatever. Management of fourth ventricular tumors with hydrocephalus, we go in first an EVD to release the pressure during the surgery. Sometimes you don't have to, but this is a possibility. And then you do a tumor removal, you do an ICP monitoring with the EVD that you leave post-operatively for 48 hours, and an ATV if needed. If it happens like the ones I showed you, proximal intercisternal obstructive hydrocephalus. Craniopharyngiomas are also doable through the endoscope, but now endonasally. So this is what you see, and this is a pre and post, and we do it with image guidance. It's at the end of the day a set of mind, knowledge, skill, learning curve, tools, your endoscopic equipments. Take-home message, prepare yourself with a tedious learning curve, focus on command of morbid anatomy and anticipate anatomical variations, expect limitations, do's and don'ts, doable or not. Convey and share valuable knowledge. And most of all, patient safety comes first. Thank you very much.
Well, thank you very much, Professor Ahmed Zuhdi, for this really very interesting, I will say it's almost a mini chapter or a book on endoscopy, specifically on the anterior part of the ventricular system and third ventricles. I'm trying to see on the screen if there are any questions. It seems you have covered most of the stuff that were no questions on from the attendance. I'd like, if you don't mind, to add a few things. I think the most important message Professor Zuhdi has given is to be flexible. You see, you don't put the indication to apply it on the patient, to check the patient you apply the proper indication. This is number one. And there are many ways of doing things. You don't stick yourself to one piece of instrument. You see, I always laugh when somebody say, I am an endoscopic surgeon. You are a neurosurgeon with using the endoscope to achieve your goals. The same with the CUSA. I laugh when somebody tell me I'm an endoscopic surgeon. I tell him, are you a CUSA surgeon? This is a tool, you use it whenever it's needed. And that's what Dr. Zehdi has proved and shown his flexibility, that when it's needed to do a mini craniotomy, he will do it. He will combine the hybrid use of endoscopy with the microscope to achieve the best for his dissection safely. Now, of course, he did not cover the other approaches. I think, although under the umbrella of hybrid use, like the atrium lesions, the different subchoroidal approaches, these approaches are made and needed whenever it's needed. They are having their merits and complications, but they have to be considered. So the trainees, they should get acquainted when they use the endoscope and the microscope on the different approaches to the different area of the ventricular system at large. Okay, like a pineal region. Now we do a unilateral infrasupra to enter to the third ventricle from behind if it's posteriorly located lesion, or if it's a pineal lesion or cyst encroaching over the posterior third ventricle. Interhemispheric was Dandy the first who described it, and now people use the endoscope. But the other word I want to say, I don't know if Dr. Zehdi concurred with me on this subject. I always say ventricular surgery needs very important knowing the anatomy, but more important knowing the venous anatomy of the ventricular system. It's a venous challenge. You see, if you go for the furnace approach, this is the cerebral veins. If you go even the foramen of Monroe, these are the landmark for you. Some people, they don't even identify it. They got lost because they did not place the borehole, as we said, vertically. And the septal vein, thalamus striatal vein, these are landmark for you to identify the foramen if it's a small foramen or there is a tumor obscuring the foramen, and which happened. And he showed very several examples. So these are the things. I agree with you 100% about choroid and ETV. I will do it always because I want to go have a night's sleep without concerning of acute hydrocephalus that can cost the life of the patient and your license. So this is a minor procedure. You can do it, and it's a very safe, and it reduces a lot of potential complications. These are what I have, and I leave it for Dr. Zehdi if he wants to add something else.
No, I just fully agree with what you have said, and it's actually an excellent statement. Regarding the tumors and the endoscope, well, I've removed meningiomas, but not, of course, endoscope assisted. I use the endoscope as a tool in order to identify the vasculature or the actual site of origin, etc., etc. As I showed you, maybe in the case with the intraventricular tumor that caused the sort of a ball and socket obstruction of the one foramen of Monroe, and actually it was such an easy surgery to go with the endoscope first, identify what's going on, and then shave the tumor from the lateral wall of the lateral ventricle, and then even additionally go in with the endoscope, and then very strangely knowing the pathology of this patient. This was a young boy, 11, 12 years, something of the sort, and this was an astrocytoma grade 2, but yet with seeding, which is very strange. I at the time, I never got a clue why did this kind of, I wouldn't say benign, but relatively not malignant tumor would do a seeding, but it was there. and changed then, or changed hence the policy to do additional radiation. So combining things together and not letting the pendulum take you to one side more than the other, and to be within the surgery flexible, although you were sort of defying everybody, I am going to do it with the endoscope alone. No, there is no time, there's no place for such ego. There is only a place for safety of the patient, safety of the patient. Even if you fail totally with endoscope, like the example I showed you with I wanted to do an ETV for a medulloblastoma in order to go into a sort of more or less quiet brain, not an angry brain. I found out the whole floor, there is okay, I could have removed the part of the tumor, shaved the part of the tumor, and then go into in the endoscope. Why? It's not in this, and even another step further, we put then a shunt with a sieve, because this patient had the tendency of seeding, medulloblastoma, 4th grade, and seeding in the target area. So and this was a sort of instant way of thinking: data acquisition, data analysis, data response. This is how a neurosurgeon should function. And this is actually, I really owe it to my mentor, the late Professor Axel Penetsky, may he rest in peace. I mean, he was talented in this sense, what to do, even if you are sort of squeezed in a situation. You should always think very quickly and revise all your knowledge and react with the interest of the patient, or to the interest of the patient. Thank you again for giving me this chance to join you. I'm always ready to convey.
I have one more, one more comment on craniopharyngioma from below. I have done couples of them, but I feel once they are heavily calcified, you should not go after it from below. If it's cystic, this is fine if it has a component going down, but a heavily calcified lesion, this is a no-go from below, because you cannot guarantee the safety of reserving the stroke properly or having vascular injury that will warrant an emergency intervention in one way or other. What I do in most of my cases, whether it's I'm doing skull base or intraventricular, I always have the endoscope next on the table. I don't say keep it in the room, because I know the time taking to mount it and prepare and take white balance. I said, make it, we are going to use it. And I agree with you, the point, sometimes you don't use it for the tumor resection, but visualization and surveillance around it. Sometimes even a meningioma, you can see the supply behind, putting a 30-degree, so you know where you are anticipating bleeders and problems, so you can prepare yourself. As you said, shaving or debulking the tumor, and then you reach that complication. This is very important, and I thank you for showing all these complex cases. It's so wonderful to have you. Thank you.
Thank you very much, Professor Zodi, and also Professor Imad Khanat. I think since there's no further question, we may move on to the second lecture. I would like to call upon invite Professor Zubin to introduce our second speaker. Professor.
Okay, thank you. At first, thank you, Professor Khanat and Professor Zohdi, for your very informative presentation and share your vast experience with us. Thank you. So now let's invite the second speaker, Professor Liao Yujun from Huashan Hospital. He is a very talented neurosurgeon, and he works with me for longer than 12 years. And now he can do a lot of independent surgeries, including the bypass. His personal experience in bypass is more than 1,000 cases by now. So, Professor Liao, please.
Thank you, Professor Shubin, for your kind introduction. Thank you, Professor Khanat and Zodi. It's a great honor to be here to sharing my conference with masters like you. And thank you, Professor Liu. Tonight, my topic is pressure-guided cerebral revascularization of giant ICA aneurysm, and case report and literature review. And first of all, let me start with a case we treated recently. And this is a female, 45 years old, and she complained of a pulsatile mass in the right neck for several years. And the physical examination indicated a pulsatile mass in the right neck, and no neurological deficit was detected. And cerebral angiogram indicated a giant fusiform aneurysm in the right internal carotid artery C1 segment. And notice the tortuous segment in ICA proximal to the aneurysm. And unfortunately for this patient, and we can see some ischemic change in the intracranial part of the right ICA. And unfortunately for her, limited ACM and PCM compensation could be detected. So for this case, our diagnosis is the right side ICA giant aneurysm in the C1 segment. And for this case, our surgical plan is to bypass and ICA sacrifice. And first, we plan to do the STA-MCA double bypass. And after that, staged ICA occlusion will be performed during a period of about 1 week. And during this time, the brain will be fed by both ICA and the STA bypass. And and about 1 week later, and the bypass will be checked. The patency, if the patency was confirmed, and the ICA will be ligated, occluded permanently. And in the end, the right anterior circulation will be fed by only STA bypass. But there's two questions in this surgical plan. The first is the low flow bypass enough? And let's go back to the angiogram. Lucky for this patient, she's got two relatively strong STA and positive remodeling of bypass, and which is like the growing of the bypass. And in our experience, and the STA-MCA double barrel bypass hold the potential to perfuse the entire MCA territory in our case series. And stage occlusion of the diseased ICA will enhance the positive remodeling. But the second question is how much of the initial stenosis will be better in the first stage after we finish the STA-MCA bypass. And physically speaking, 70% stenosis of the ICA would result in the decrease in the cerebral perfuse pressure. But that's in physical condition. What would be happen in pathological condition like this patient? And actually, we still lack of accurate or quantitative evidence for decision making during the first stage operation. Of course, nervous system and cut flow index are options. And here in this case, we think about the cortical pressure monitoring, and we believe it may be a new way. And according to our experience, some stenosis in the ICA will result in the decrease of the cortical branch, like M4 segment. So the cortical branch maybe act as a reflection of the blood flow. By measuring the cortical pressure, we can know whether the bypass flow is enough to feed the MCA or the ICA territory. But speaking of the measurement of the cortical branch, as we mentioned in previous webinar, because the M4, the cortical branch, is very thin and fragile, and the direct puncture or detection of the pressure is almost impossible. But after we finish the anastomosis, and we can insert a pressure wire into a side branch of STA and creating a closed system. And in this closed system, we can measure blood flow pressure of different pathways by open or close of different arteries. For example, if we close the donor STA here, and the blood flow from MCA would go retrograde to the detector, and we can measure the pressure of the cortical branch. And go back to this case, and firstly, we performed two STA-MCA bypass anastomosis site here and here. And after that, we inserted the pressure wire into a third branch of the STA, and now the closed system for measurement is established. Of course, the mean arterial pressure was maintained at a relatively stable around 80 millimeter mercury. And after that, we open the right neck and expose the CCA, the ICA, and ECA, and of course the large aneurysm here. Notice the tortuous initial ICA segment. And this is a special designed clamp for the staged occlusion of the ICA. This is specially designed by Professor Shibing. And this is when it's closed, and when it's open. It's a X shape and with a structure of symmetrical structure. And the anterior part of the clamp was for holding and closing of the ICA, and the posterior roller is for narrowing or open of the ICA. And the posterior part of the clamp will be left outside the wound for further the second stage adjustment of the ICA stenosis or close. See the clip of the ICA and the narrowing of the ICA. To be mentioned is these two gap is equal. This is to hold the ICA. This will be left outside the wound. Okay, now the first thing is to measure the baseline M4 pressure, and it's 66, indicating when the brain was fed by the diseased ICA alone, the cortical branch will be 66. And after that, we narrowing. See here, we're narrowing the ICA in the neck, proximal to the aneurysm, and we can find a decrease of cortical branch from around 66 to 42 now, and 44. And in the end, the cortical branch stable at around 47. Sorry. At around 47. And now we know the baseline is around 66. So And now the ICA is totally occluded. Now we know during the first stage operation, the STA alone, bypass alone, couldn't maintain the normal baseline perfusion of the brain. So the ICA could not be sacrificed immediately during the first stage operation. And so we reopened the ICA partly and to maintain the M4 pressure at around 62, almost near the baseline level. This is the increasing of the cortical branch. We partly slowly open the ICA C1 proximal to the ICA, and the pressure of cortical slightly increasing from around 47 to 60 millimeter mercury. And the pressure stable finally at around 62 millimeter mercury. To be mentioned is that maybe because of some mechanical error, so we cannot maintain an accurate M4 pressure at 66, just as the baseline level. So let me take a small summary of the first stage operation. So at baseline, the right hemisphere anterior circulation is fed by ICA alone, and the M4 cortical branch pressure will be 66. And after the double barrel bypass, STA, MCA, and the ICA occluded, the M4 pressure dropped to 47. There's around 20 millimeter mercury gap. So we partly opened the ICA, and this time the right hemisphere was perfused by the double barrel bypass and a narrowed ICA. So during the first stage operation, the cortical branch pressure is our main focus. And of course, and our procedures on the continuous MEP and SEP monitoring. And to be further clearance, let me summarize again with the help of a baseline. So at baseline, before operation, the ICA alone can maintain a cortical branch at 66, and after the double barrel bypass, and it can maintain only 47 at the cortical branch. And so we believe the ICA couldn't be sacrificed immediately. So we reopened partly the ICA, and during day 1 to 6, the right hemisphere was perfused by double barrel bypass and narrowed ICA. And during this time, the ICA is generally occluded and the STA is generally growing. And 1 week later, and we recheck the DSA and confirm the patency and found the STA is getting stronger and diameter is increased. And we hope the cortical branch may be larger than baseline. And now let's go to the second stage in real world. And during the 7 days, it took 3 times to close the residual caliber of the right ICA, about 1.5 millimeter each time, around 10%. And the main risk is ischemia. And of course, the neurological function was under tightly monitoring. And to be mentioned is the specially designed clamp. The best advantage of the clamp is reversible. In case with ischemia, we can reopen the ICA for tailored adjustment. And now 1 week later, the follow-up angiogram indicated the patency of the double barrel STA MCA bypass. And luckily for this patient, the ACN opened well. And after operation, the patient recovered well, and the CT scan, no signs of ischemia or any abnormality. And the CT perfusion indicated no signs of low perfusion in the right hemisphere. And of course, MR scan, no signs of acute ischemia, cerebral infarction. And the patient was discharged uneventful about 10 days after the first operation. And now let me take a small review of the blood flow replacement surgery of ICA. During the last 2 decades, we used this method to treat several kinds of neurosurgical diseases, not only giant aneurysm or complicated skull-base tumor, but also malignant tumor like the nasopharyngeal carcinoma. And in the surgical plan of this procedure, of this operation, there's 2 important questions to be decided. The first is how much blood flow is needed from the bypass. And the second one is how soon to close the diseased ICA. Of course, the balloon occlusion test is the first thing to do. It will decide the need for ECIC revascularization. If the balloon occlusion test is negative, and we can sacrifice the ICA immediately. But more important thing is which operation we can use, the high flow, low flow, or medium flow. And here we raised a paradigm for the procedure selection. And we believe a simple way is to use the perfused area of the diseased ICA, simply speaking, like this slide. And if the diseased ICA only need to perfuse the ipsilateral MCA and maybe a low flow bypass like STA MCA, double or single bypass will be enough. And in the second type, when the ICA need to perfuse ipsilateral MCA and ACA territory, maybe a medium flow bypass will be used. And in case with bilateral ACA and ipsilateral MCAs perfused by the diseased ICA, and a high flow bypass will be needed. Let's take some real cases for illustration. And this is a case we used a venous vein graft for the bridge. And this is post-operative control angiogram. We can see the bypass flow, perfused ipsilateral MCA and bilateral ACA territory. And this is a special case, and a large tumor involved bilateral ICA, and luckily for this patient, the ACN opened well. So for this patient, we performed the left side high flow bypass with a venous vein graft and STA MCA double barrel bypass. And in the end, the follow-up angiogram indicated the bypass in the left side could perfuse the bilateral anterior circulation. You can see the high flow bypass here, and this is the venous graft, and the 2 low flow bypass stoma here. And bilateral ICA is occluded for further resection of the tumor. And this is a case of a medium flow bypass, also a giant aneurysm in the left side. And we here we used a radial artery graft. These are stomas in the neck and in M2. And follow-up angiogram indicated the patency of the bypass feeding ipsilateral MCA and ACA territory. And this is also a case with a large aneurysm in the right ICA, and there are some compensation from ACAN and PCAN, but CT perfusion during the balloon occlusion test indicated some low perfusion in the right hemisphere. So we adopted STA-MCA double barrel bypass to avoid delayed ischemia. And this is the angiogram after the operation. And we also coiling the ICA after the confirmation of the bypass. And now let's come to the other question, is how soon to close the diseased ICA. Of course, the staged occlusion will be a solution, and the staged occlusion of the ICA could be combined with different procedure, high flow, low flow, or medium flow, and it could facilitating the positive remodeling of bypasses and increasing the compensation like ACAN, PCAN, and peer collaterals, like this, the lower left. And we can find the STA-MCA bypass getting thicker obviously in the right side, and this one ACAN's not so good before operation, and several days after the staged occlusion of the ICA, the ACAN opened well. At least to some extent, we can get some compensation from the ACAN. And special designed clamp will be needed to for the staged occlusion of the STA. This is the first generation we used in our department, and this one, the right one, is a new one designed by Professor Shibing. And so far, we only have one piece of this, and as X-shaped, as we mentioned before. And notice here, the posterior part with the roller will be left outside the wound for further close or open of the ICA. And this distance is equal to the anterior part, which will hold the ICA. And we mentioned this before, so I will skip this. And these are cases we've done recently, and shows the dissection of venous and arterial graft. And this is the radial artery, and this is the venous vein. This is the venous graft, and this is the radial artery graft. And notice the posterior part of the special designed clamp for the staged occlusion here and here. And this is a case of a medium flow bypass with radial artery graft. And these are two cases actually. The first, they both treated by low flow bypass. Notice here, we can see the ICA from severe stenosis to totally occlusion by the special designed clamp, and the STA-MC bypass getting stronger and stronger. And we can find the blood flow when retrograde to almost M1 segment, actually even close to the ICA terminal part. So let me take a small summary. And bypass, ECIC bypass combined with staged occlusion of ICA is safe and effective. And procedure selection based on feeding area of diseased ICA is reasonable and effective. And specially designed clamp is helpful, quantitative, accurate, and reversible and safe. And in the treatment of complicated ICA disease, and which can providing a possibility of tailored adjustment, maybe 7 days or longer, which would facilitating positive remodeling, which is the growing of bypass and spontaneous collaterals like ACN or PCN and peer collaterals, and pressure-guided narrowing of the ICA during the first stage of operation is reasonable and effective and safe in this case, and which could providing an accurate and quantitative way for decision making. But this is also the limitation of this method, because we can only use this the pressure wire in the first stage operation, and we cannot use it after in the second or the third stage operation. Maybe we can combine with novel system and for further research. Okay, thank you very much.
Okay, thank you, Dr. Liao. And this is our original research for this kind of progressive occlusion of ICA. Just as Dr. Liao mentioned, that this kind of treatment is safe and reversible. And at the first stage, we make the proximal part of the ICA narrowed, but according to our experience, we have no accurate data to measure the pressure or the blood flow of the cortex. So like this case, it's at the first stage, the cortex M4 segment, the pressure, if we totally occluded the ICA, the pressure decreased to 44 millimeter mercury. This is quite dangerous because this pressure is close to the Moyamoya disease. But Moyamoya disease have the patient have a lot of collateral small vessels from normally they already get used to this low pressure irrigate system. But if it's acute decrease of the pressure, the patient may form some stroke. So we make the pressure around 62, so decrease a lot, not very much, and make the patient safer. So with the hip decreased accurately recorded by the probe. So we created the positive delta P from ECA branch comparing to the ICA branch. So we can make sure the blood flow competed between the ICA and the ECA. The ECA can win and the blood flow can come to the intracranial positively. And after 7 days, we can make the totally occlusion of ICA. The pressure from the ICA can be decreased a lot, and the blood and the diameter of the STA can increase and the blood flow from increased a lot with the progressive decreasing of ICA, and the contralateral ACAM and the PCAM can also have time to getting larger, and the blood flow from collateral blood flow can also increase. So this kind of treatment can make some high flow or medium flow. Sometimes we don't need to do the medium flow bypass, just need the STMCA double bypass. So makes the treatment simple and safer. That's all. Is there any questions from audience and the professors?
I just want to commend you and Dr. Liao on the studies, and I'm very glad that you kept the field moving forward of the perfusion and vascular in the field and in the hand of the neurosurgeons, so we are not completely excluded. Bypass is a procedure here to stay, and you showed that it can be improved, and with some technological and strategies you have mentioned here in that presentation. So congratulations for both of you.
I have one question.
Thank you for
Professor,
your comment, Professor.
if you allow, yes. Okay, probably Professor Zodi first. Professor?
Yes.
Yes.
First of all, I would like to congratulate you for this excellent and actually very difficult work. I mean, this kind of bypass surgery is a challenge, and it's sometimes not a very rewarding one. So you have to be very patient in order to achieve whatever goal you want to achieve. And of course, it is a major part of the training program, not of course at this stage or that stage that you are performing, but at least the basics should be there to each and every resident in his last year of training. It is something, and in order to some sort of implement a strategy that these young neurosurgeons should be able to go through this experience, and because most of the neurosurgeons I know who went away from such kind of surgeries did not try it at all. So they did not go through the experience or the sort of beginner's experience to be able to continue or to like this kind or to be interested in this kind of very, very difficult neurosurgical subset. Thank you again for this interesting lecture or presentation, and I wish you all the best for the future.
Thank you. Thank you, Professor, for your comment. Thank you.
One question for you, Dr. Liao.
Yes.
You did demonstrate that you were able to measure the bypass pressure, and obviously at the beginning the STA would not have enough pressure to support the pressure in M4.
Yes.
And do you subsequently monitor with some sort of cerebral oxygenation monitoring like INVOS to compare as the comparison when you do a gradual or stage occlusion? Would that?
Thank you for your question. I'm wondering, do you ask if we can use the iliac kind of procedure like radial artery graft?
No. Brain oxygenation, INVOS. Using INVOS, beside looking at the pressure difference, would that oxygenation be give some?
Other way for monitoring. Yes, of course. I think it's a good idea, and maybe in further research we can combine these technologies together, like the nervous system and the oxygen level of the brain surface, as you mentioned. Thank you for your suggestion.
Thank you for the excellent presentation, Dr. Liao.
Yeah, thank you.
I think I didn't see any further question. Probably we can hear the concluding remark from Professor Zubin. Professor?
Okay, thank you, both speakers, and thank you, Professor Kanan, for hosting the first session, and both speakers, Professor Zohdi and Professor Liao, and they make the outstanding presentation today. Thank you.
Thank you very much, Professor Zubin. So we are officially closing the webinar for today. On behalf of the Education Committee of the ACNS and President Professor Okato, I would like to thank both speakers today, Professor Ahmad Zodi and also Professor Yu Jun Liao, and also our both chair, Professor Imad Kanan and Professor Zubin, and for their time and support for the ACNS webinar. And also thank you for Professor Zubin again for broadcasting this webinar in WeChat channel, and we have 1,000 over spectators for tonight. And we're going to meet again next Saturday. It's bye-bye from all of us. Thank you, Professor. Good night.